It is now my pleasure to turn today's program over to Marcia Griffin. Marcia, the floor is yours.
Thank you, and thanks everyone for joining. It is my distinct pleasure to introduce our co-speakers today, both Dr. Mo O'Gorman and Dr. Vijaya Knight, who share between them over 60 years of experience in immunology and flow cytometry. Dr. O'Gorman earned his master's and PhD at the University of British Columbia before he completed a postdoctoral fellowship at the University of North Carolina at Chapel Hill. He then joined the faculty at the Feinberg School of Medicine at Northwestern University, during which time he earned an MBA from Northwestern and served as the Vice Chair of Pathology and Laboratory Medicine and the Director of Diagnostic Immunology and Flow Cytometry at the Children's Memorial Hospital in Chicago. Dr. O'Gorman is currently the Chief of Laboratory Medicine, as well as the Director for the Clinical Lab and the Diagnostic Immunology and Flow Cytometry Lab at the Children's Hospital in Los Angeles. He's a Professor of Pathology and Pediatrics at Keck School of Medicine. Dr. O'Gorman's research interests include the immunopathogenesis of immune system-related disorders, the investigation of immune mechanisms of immune suppression, withdrawal in liver transplants patients, and the development of novel immune-related diagnostic laboratory tests. Additionally, Dr. O'Gorman provides ad hoc reviews for multiple journals, including Cytometry, the Journal of Leukocyte Biology, the Journal of Immunological Methods, Clinical and Diagnostic Laboratory Immunology, and the Archives of Pathology and Lab Medicine. Dr. Knight received her medical training at Maurice Medical College in India, graduating in 1991. She then completed a residency in neuromicrobiology and immunology at the National Institute for Mental Health and Neurosciences. Following her residency, she obtained a PhD in immunology from Melbourne University in Australia, followed by 3 years of postdoctoral work at the University of California in San Francisco, where she studied the interaction of tuberculosis with the interferon gamma signaling pathways in human monocytes and macrophages. She then spent 2 years as a Juvenile Diabetes Research Foundation Fellow at UCSF, where she worked on T-cell regulation in models of autoimmune disease focusing on type 1 diabetes. Dr. Knight then transitioned to the biotechnology industry and spent a couple years working for MedImmune as a research scientist and with the Translational Biology Group. Dr. Knight joined National Jewish Health in 2008 and is currently the Director of the Advanced Diagnostic Immunology and Flow Cytometry Laboratories at National Jewish. She's an Associate Professor in the Division of Pathology within the Department of Medicine. In addition to overseeing the Clinical Immunology Laboratory, Dr. Knight is also involved in developing new diagnostic assays for patients with immune deficiency and autoimmune conditions, as well as the development of immune monitoring tools for clinical trials. Additionally, she's involved with teaching undergraduate and graduate students, as well as training allergy and clinical immunology fellows in immunology laboratory methods. Dr. Knight is an active contributing member of the Associate of Medical Laboratory Immunologists, the Clinical Immunology Society, the American Society for Pathology, and the College of American Pathologists. She's on the Diagnostic Immunology Resource Committee for CAP, the College of American Pathologists, and as an active member, she's been invited to speak at a variety of national and international meetings. Please help me in inviting her as she's going to kick off our session today. Thank you, Dr. Knight.
Thank you, Marcia, for that introduction. It is my distinct pleasure to join Dr. O'Gorman in bringing you this webinar today. Dr. O'Gorman is from the Children's Hospital of Los Angeles, and I am at National Jewish Health Advanced Diagnostic Laboratories in Denver, Colorado. So today we'd like to discuss the utility of TBNK flow cytometry phenotyping of lymphocytes beyond HIV. The field really started with HIV, and what we would like to discuss today is the way the field has moved beyond human immune deficiency virus, diagnostics and monitoring to other forms of immune deficiency. The objectives of our talk are listed here. We will be going through immune deficiency, definition and causes, a brief description of immune cell subsets and their development, the technology of flow cytometry and how we use it diagnostically. We will be talking about the utility of CD45 gating of lymphocytes to better identify these subpopulations of white blood cells, single and dual platforms for absolute lymphocyte subset counts, and we will talk about the past and present routine immunophenotyping panels with quality control monitoring, measuring CD4 T cells in HIV infection, as well as moving on to immunophenotyping in primary immune deficiency diseases, along with the classification of immune deficiency disease, the scope, and some case studies to illustrate how flow cytometry is useful in making a diagnosis in these cases. So to start us off, what is immune deficiency? We define it as missing a portion of the immune system. So in some cases, the patient may be missing one of the particular subtypes of lymphocytes, causing them to be susceptible to infections, or it's a state in which the immune system's ability to fight infections is compromised or entirely absent. In some cases, the phenotype of the immune system may be normal. However, the immune system could be functionally compromised. So in such cases, we might actually detect certain subsets of cells by flow phenotyping, but they may be functionally compromised. So what are the causes of immune deficiency? Primary or intrinsic immune deficiency is attributed to inherited genetic defects that affect the phenotype or function of the immune system. And these defects may present early on in life or perhaps later on. The key part of the inherited defects is that there is a genetic link and they can be transmitted to subsequent offspring in families. Secondary or extrinsic causes of immune deficiency, of course, the best known is human immune deficiency virus or HIV. But beyond that, there can be certain biochemical perturbations, as in diabetes, where the immune system may be affected, making a person more susceptible to infection. Protein loss syndromes, some of these might include malnutrition, dialysis, or burns, or treatment with immunosuppressive agents, for instance, steroids or B-cell depleting agents like rituximab. So in these cases, the immune system, too, is iatrogenically or therapeutically suppressed, making a person more susceptible to infection. Immune deficiency, when we think about the different types of cells involved in the immune system, we can broadly classify immune deficiency into 5 different buckets, as we like to consider. The biggest sector of immune deficiency are due to antibody deficiencies. As shown here, about 65% of immune deficiencies we encounter in our patients are due to either inadequate production of antibodies or the inability of these specific antibodies to be made against particular vaccinations or infections. And they form the large part of the immune deficiencies we tend to see. These patients can be inordinately susceptible to bacterial infections, and they can present with upper respiratory tract infections or repeated ear infections. The rest of the immune deficiencies are really much more rarely encountered. About 10% are due to phagocytic defects, and these phagocytic cells are most commonly comprised of granulocytes, neutrophils being the largest component, and to a certain extent the macrophage population. These defects tend to manifest in the younger age group and present with overwhelming bacterial or fungal infections. About 5% are due to defects of the complement system. The complement system is a cascade of proteins and is considered to be the first line of defense in many cases. This protein, the system of protein cascades is conserved through evolution and is critical for the clearance of bacterial infections. Again, although uncommon, complement defects that are inherited can lead to overwhelming infections. Another 5% of immune deficiencies are cellular in nature, and we think of these as mostly to do with T cells, while 15% could be a combination of cellular and humoral immune deficiencies. So in other words, a combination of antibody defects and T cell defects. So when do we suspect primary immune deficiency? There are 10 warning signs that we look for that are suggestive that it is warranted to investigate the patient for evidence of immune deficiency. And these are listed out here, published by the Jeffrey Modell Foundation. 4 or more new ear infections within a year, 2 or more serious sinus infections within a year, 2 or more months on antibiotics with little effect, 2 or more pneumonias within a year, failure of an infant to gain weight or to grow normally, recurrent deep skin or organ abscesses, persistent thrush or fungal infections, the need for intravenous antibiotics to clear infection, 2 or more deep-seated infections, including septicemia, or a family history of primary immune deficiency. So these warning signs would prompt us to investigate the patient for any possibility of immune deficiency. So what do we look for when we are investigating a patient for the possibility of immune deficiency or missing part of their immune system or a functional defect in immune cells? So to help us understand this, it's always good to have an overview of the immune cells, the cells that constitute our immune system, and how they develop. And presented here is a cartoon of the development of these various types of immune cells. They all start off from a common hemopoietic precursor in the bone marrow, and then can take 2 pathways, either the lymphoid pathway or the myeloid pathway. If we follow the lymphoid pathway, the common lymphoid progenitor can give rise to B cells, which again can mature into plasmablasts that produce antibodies, or memory B cells that retain memory of having encountered an antigen, be it a vaccine or an infection, and then that allows them to make specific antibodies when this particular antigen is encountered again. The lymphoid progenitor could also develop into a T cell. The 2 major types are the CD4 and CD8 T cells, also commonly known as helper cells and cytotoxic T cells, although these functions in recent times we've known can overlap more than expected. Lymphoid progenitors can also develop into natural killer cells that are very important for clearance of viral infections. Along the myeloid pathway of development, cells can either take the monocytic pathway of development and develop into macrophages or dendritic cells. These are what are called classic antigen-presenting cells that are responsible for processing antigens, be it either a vaccine or an infectious agent, and presenting them to T and B cells to then generate specific antigenic responses. Myeloid cells can also take the pathway of developing into the granulocyte cells, which include neutrophils, eosinophils, basophils, which are found in blood, and mast cells, which are the counterpart of basophils found in tissues. So a block at any stage from development through differentiation can lead to a lack of one or more of these cell types. It really depends on where the genetic defect lies. If it's early on in development, multiple cell types can be affected. If it's later on in development, then perhaps a subset of these cells may be affected. So how do we work up a patient when we're suspecting immune deficiency? What we would like to do is to get a broad assessment of the immune system to start with, And we can do that by analyzing their complete blood count, which would include white blood cells and red blood cells. We would analyze peripheral blood immune cell subsets using the TBNK flow panel, which we will be discussing in more detail. Serum immunoglobulin levels, IgG, IgM, IgA. Peripheral blood lymphocyte responses. So we would determine whether lymphocytes are present and can they respond to stimulation. We would look at neutrophil oxidative burst. Again, this is, although rare, one of the more common granulocyte deficiencies. And we would also look for complement activity by testing for what's commonly known as CH50 and examines the ability of the complement pathway to activate appropriately. So this constitutes a general workup for immune deficiency. And of course, if one or more of these tests is abnormal, then we would like to follow up in more detail to see which part of the immune system is affected. Now, flow cytometry really it revolutionized our ability to enumerate and characterize immune cell subsets. So apart from complement defects, if we do find a defective test for any of the cellular components, we can make use of flow cytometry to follow up and examine the immune system in far greater detail to determine where the defect lies. So let's talk a little bit about flow cytometry and what are the advantages of using flow cytometry. Cytometry or microscopy has been around for a long time, and it has allowed us the advantage of taking tissue sections or cell suspensions and putting them on a slide and staining them to localize specific antigens. However, it does have the disadvantage that we cannot enumerate multiple cell subtypes, and we can only do a couple of simultaneous measurements. We might be able to detect CD4 cells and CD8 cells on a tissue section, but beyond that, it becomes incredibly difficult to look at many more parameters. So flow cytometry offers several advantages over cytometry or microscopy. Of course, localization is not possible because in flow cytometry, we're really looking at a suspension of cells. We're not looking at a tumor section. However, we're able to analyze many, many more cells in a short amount of time, and we can examine many parameters at the same time. So let's talk a little more about the technology of flow cytometry and how this works. So flow cytometry, what we require here are for cells to flow in a single file such that they can be interrogated by a light source or laser, which allows us to determine the properties of these cells. And then we collect these signals, they're converted to digital values, stored in a file, and this file can be read by specialized software. So the four components of flow cytometry, the cells flowing in a single file is what we term fluidics, which we'll discuss in a little more detail. The interrogation by the light source, which tells us a lot about the properties of the cells. The conversion of those signals by the electronics of the instrument, and the software that then allows us to interpret these signals and look at the data and analyze it in the context of our patient. So let's talk a little bit about fluidics and how does this work. So the flow cytometer has a core of sheath fluid that's under a certain amount of pressure. Cells are injected into this core of sheath fluid, cells in suspension, so they may be from peripheral blood, they may be from a tumor or a tissue source that has been converted into a single cell suspension. And these cells are passed through the fluid sheath in a single stream using what's called hydrodynamic focusing. The pressure of the sheath fluid causes a drag on the cells in suspension as they pass through and allows them to pass through in single file. As they pass through in single file, the light source then interrogates each cell or event as it passes through. And the amount of light scatter can be collected, which we'll discuss in a little more detail, that tells us a lot about the type of cell that this is. So what does the laser beam tell us as it hits each cell as it passes through? So the light that falls upon the cell can be blocked parallel to the laser beam, as you can see in this figure, and that tells us something about the size of the cell. Light can also be scattered by the internal structures of the cell, and as you can see in the figure below, the cell here is more complex with a segmented nucleus and granules, and light is scattered to a far greater extent. So the light that is parallel to the laser beam is something that we call forward scatter, and tells us something about the size of the cell. The greater the forward scatter, the larger the size. The light that is scattered in multiple directions is generally collected at right angles to the laser beam, and we call this right angle scatter or side scatter, and it tells us a lot about the complexity of the cells. So if we graph this out and look at forward scatter on the x-axis, side scatter on the y-axis, and we can see that smaller, less complex cells will have lower forward scatter and lower side scatter. The larger, more complex cells are slightly larger with their forward scatter and side scatter. And of course, the largest and most complex cells are all the way at the top, being much greater for forward scatter and for side scatter. So how does this work if we just took a sample of peripheral blood and put it through the flow cytometer without doing anything else to it? What sort of information could we get? So just taking forward and side scatter properties can tell us a lot about the types of cells in peripheral blood. Now shown here on the x-axis is forward scatter. On the right y-axis is side scatter. And as you can see, the cells that are lower in forward scatter, lower in side scatter are lymphocytes. They're smaller, not very complex. The larger monocytes, little more complexity, so they're slightly larger than lymphocytes, slightly more complex. And the granulocytes form a smear all the way at the top. They are larger and certainly a lot more complex. You can also see that red cells, debris, and dead cells, which are much smaller, come out to the left of this lymphocyte population. So just taking forward and side scatter, which correlate to size and internal complexity, will allow us to differentiate multiple types of cells in heterogeneous populations such as peripheral blood. So while we can distinguish these populations, as immunologists, what we really want to know is what else can we say about these lymphocytes. So it isn't enough for us to detect lymphocytes. We want to know, are they T cells or B cells, are they CD4 or CD8? And the way we do that is to tag these cells with antibodies that have specificity for these molecules expressed on the surface of the cells or even within the cell. Now these antibodies are tagged with fluorescent dyes. We incubate them with the cells. The antibodies bind to their specific molecules, and then we can analyze them by flow cytometry using the fluorescence that these dyes give off, knowing that they're conjugated to specific antibodies. So as an illustration here, you can see that T cells are tagged with anti-CD3, which is expressed on all T cells in green. But CD4 T cells are tagged with an antibody that only recognizes CD4 and has a red fluorescence. By contrast, CD8 cells are tagged with both CD3, that's common to T cells, and CD8 in purple, that is specific to the CD8 T cell. So fluorescence, which allows us to distinguish different types of lymphocyte populations. How do we use flow cytometry to measure these fluorescent molecules? As the laser interrogates the cell, we know that we can pick up forward scatter and side scatter to give us a sense of the size and complexity of the cell. If the cell is tagged with fluorophores or fluorochromes, as the laser interrogates the cell, the fluorochromes absorb some of the light and get excited. So as they get to ground state from their state of excitement, they release energy in the form of a photon that has a specific wavelength. And these photons are then steered down through a system of collection lenses and specific channels with the use of filters. And so we're able to pick up specific wavelengths corresponding to specific photons that have been released from specific fluorophores that in turn were tagged or rather conjugated to specific antibodies recognizing a cell surface marker. So this then gives us a sense of how flow cytometry works when we put it all together. As you can see in the figure, the sample goes through the sheet fluid through hydrodynamic focusing into a single stream. The cells are interrogated by the laser beam. We collect forward and side scatter signals that tell us about the size and complexity of the cells. The fluorescent molecules on the surface of the cells then go through a system of band pass filters that allow only specific wavelengths to go through. So for instance, if we're considering the blue fluorescence, which only has a range of, say, 400 to 500 nanometers for argument's sake, these filters will collect only those wavelengths and transmit them to photomultiplier tubes. So similarly, the fluorescence from different antibodies can actually be sorted out from the same sample, allowing us to not only distinguish size and complexity, but the types of markers that are present on the surface of these cells. The photomultiplier tubes measure these signals. So they measure the voltage changes as well as the time, the duration of these voltage changes, and convert this to a pulse height. This corresponds to fluorescence intensity. So at this point, we have collected signals from our fluorescently labeled cells that we're able to now use our software to analyze these signals and determine what types of cell populations we have in our sample. Now, using different fluorophores can be a bit challenging because the photons corresponding to these fluorophores may actually overlap in their wavelengths. If you look at the graph on the left, you can see that green fluorescence and yellow fluorescence to some extent overlap, as does orange and yellow. And so it's very important for the software to be able to discriminate clearly these distinct peaks of fluorescence, or the maximum peak at which these fluorescent molecules are emitting certain wavelengths. So the software employed by flow cytometry uses mathematical calculations known as compensation, which allow us to discriminate between an antibody with green fluorescence versus one with orange fluorescence. If you take a look at the graphs on the right, you will see that one of the graphs, the top left in this panel, shows you what two populations of cells stained with different fluorophores would look like if they were not compensated correctly. We see a smear of the population going up in an oblique line, and it really doesn't allow us to discriminate these populations very clearly. After compensation, however, the two graphs on the right, upper and lower, show you the two populations distinctly in a straight line that allows us to discriminate a population stained with a specific marker on the x-axis in the top panel and with a specific marker on the y-axis on the lower panel. So compensation is a very powerful and essential tool of flow cytometry that allows us to not only stain cells for multiple markers, but allows us to resolve this fluorescence clearly so we can discriminate the different populations. So let's move on to the utility of flow cytometry now. Since we have explored the technology, how do we use it to perform a simple TBNK analysis when we're suspecting immune deficiency? So TBNK analysis, which is a term commonly used, refers to the lymphocyte immunophenotyping usually peripheral blood, where we're discriminating T cells, B cells, and NK cells. And among the T cells, we're able to discriminate CD3 T cells, CD3, CD4 positive T cells, CD3, CD8 positive T cells. In our TBNK analyses, what we look for are the percentages of these cell subsets in peripheral blood, as well as the absolute values for each of these populations. Now, we can perform TBNK analyses using a dual platform, which I will discuss, and a single platform analysis, which Dr. O'Gorman will talk about in the next few slides. So what is the dual platform analysis? It is still used in some laboratories across the country. And what it makes use of is a flow cytometer to look for the percentages of these individual lymphocyte populations. And a second platform, usually a hematology analyzer, either a 3-part or 5-part differential, to calculate absolute counts of TBNK lymphocytes. So we're making use of 2 instruments as opposed to the single platform where you can do the entire analyses on 1 instrument. The important point for calculations here is that if we are using our white blood cell population to get our percentages of lymphocytes or subsets of lymphocytes on the flow cytometer, it's important we use the same denominator for calculation of absolute counts on the hematology analyzer. So it's either lymphocytes or leukocytes. So let's take a look at TBNK analyses performed on the dual platform. This is an example of a 2-tube analysis. Tube 1 analyzes the T cell subsets, CD3, CD4, CD8, and tube 2 analyzes T cells, CD19 B cells, and NK cells. So if you take a look at the plots on the very left of this panel, you will see in red that we use CD45, a pan-leukocyte marker, gating in order to clearly distinguish lymphocytes from the rest of the cell populations. And shown in the arrows are basophils, which tend to be lower in CD45 and slightly smaller than lymphocytes, as well as the larger monocytes that are just above the lymphocyte population. CD45 gating allows us to clearly distinguish this lymphocyte population away from the contaminating basophils and potential monocytes. In the middle panel, the upper middle panel, you can see that we are gating on CD3. These are CD3 positive T cells. It's essential to be able to very clearly distinguish them from non-T cells that could contaminate our population and skew our results. So CD45 primary gating, CD3 secondarily to ensure we detect our T cells clearly. In tube 2, similarly, CD3 gating allows us to clearly separate the T cells from the non-T cells, which should be B and NK cells. And it also ensures quality control because the percentage of CD3 cells from tube 1 and tube 2 should be approximately the same within a difference of about 5%. So how do we calculate absolute counts using dual platform analysis? So in this figure, on the left, you see our flow cytometry data, where we have CD3 T cells from tube 1 and tube 2. We take the average percentage of those 2 numbers, and we expect tube 1 and tube 2 to be within 5% of each other. We take the percentages of CD4, CD8, CD19, and NK cells. So that is the information from our flow cytometry data. Our hematology analyzer data gives us the white blood cell count, in this case 9,800 cells per microliter, and also gives us the percentage of lymphocytes, 25%. So from here, we can calculate our absolute number of lymphocytes, 25% of 9,800. And using that information and the percentages of our cells from our flow cytometry data, we can calculate the absolute counts of all the other lymphocyte subsets. So dual platform analysis requires a little more calculation from 2 independent from two independent data sets coming from two platforms. The quality control rules that we look at are that the sum of the lymphocyte populations, T, B, and NK cells, should add up to close to 100%. We take a range of 95 to 100% as being acceptable. The sum of CD4 and CD8 T cells should equal CD3 T cells within a margin of 5%. If that is much larger, we either go back to our data and see if it needs regating, or we may be looking at perhaps an immune deficiency or dysregulation that warrants more exploration to see which populations were missing. And then, as I mentioned before, in terms of QC rules, the percentage of CD3 from tube 1 should equal the percentage of CD3 from tube 2 plus or minus 5%. So with that, I would like to turn the floor over to Dr. O'Gorman. Dr. O'Gorman is going to continue to discuss the single platform analyses as well as immune deficiency testing.
Thank you very much, Dr. Knight. That was an extremely elegant overview. All I'm going to do now is elaborate a little bit on what Dr. Knight had presented. It's a little more evidence surrounding the recommendations that we use CD45 gating for lymphocytes. I'll expand a little bit on the ability to enumerate absolute lymphocyte counts directly off the flow cytometer, what we call a divorce from hematology. And then we'll talk a little bit about the panels. I think Dr. Knight presented very elegantly the 3 and 4 color tube panel for immunophenotyping. So I'm going to go previous to that in terms of what we used as the recommended panel to after that going to a 6-color potential single tube immunophenotyping plus a control tube that we have added in our panel. We'll then address some of the biology of immunophenotyping, looking at really what brought us to this stage of our clinical immunophenotyping repertoire in the laboratory, which has expanded tremendously. So we'll talk a little bit about kind of the past and present developments, understanding, and utility of measuring CD4 T cells in HIV infection. We won't talk much about the recommendations, and then most of the time we will spend addressing routine immunophenotyping and primary immunodeficiency disease. And we'll do that really by introducing you to the scope of the primary immunodeficiency diseases with a formal classification system. And then depending on how much time we have, exactly where we'll get to presenting cases of the primary immunodeficiency diseases based on the classification schema. So just again to reiterate, if you look in the flow cytometry textbooks, you're going to see beautiful pictures of light scatter, presentation of a lysed whole blood, where you have beautiful separation between lymphocytes, monocytes, and granulocytes. In reality, what we see in the laboratory more often looks something like this, where anyone would be really challenged to find out where lymphocytes start and stop. And so how do you separate between the lymphocytes, the lysed red blood cells, lymphocyte blasts, and monocytes? Hence the recommendation to apply a surface marker for lymphocytes, which is the CD45 gating reality. This really came to realization with the evaluation of severely compromised immunodeficiency patients, which led to the generation of guidelines from the NIAID, which were published late 2002, essentially recommending that we use CD45 gating to phenotype lymphocyte subsets. And we have carried this guideline recommendation onto phenotyping in primary immunodeficiency disease. So Dr. Knight presented very elegantly how you get absolute counts by combining the parameters of your hematology analysis, your absolute lymphocyte count, with the percentages off the flow cytometer. As we got involved in clinical trials for HIV, we quickly understood that there was a lot of variability generated by the different hematology systems using different technologies for the differential. So there was a big push to try to get absolute counting directly off of the flow cytometers. I had the fortune of being assigned as the director of the New Technologies Evaluation Group for the NIH to essentially lead studies to evaluate the new technologies. And so we completed 4 or 5 studies to evaluate the new technologies. The first technology that we knocked off was a new technology called laser scanning volumetric cytometry. Very simply, this was scanning a capillary tube with a known volume where you had dual positive 3,4 or 3,8 and you simply counted them in a known volume. So the new single platform technologies that are on the market today, some of the technologies do use volumetric, known volume and known amount of events where it's a very simple calculation. The technology that essentially eclipsed these technologies were bead-based, and we evaluated two different bead-based technologies, one by Beckman-Coulter and another by Becton-Dickinson. These have really taken off, more so in Canada and Europe and other countries. United States has been less diligent in really converting to single platform technologies, mostly because there is an increased cost. And so the bottom line with the technologies that we found out from our multi-center studies is basically, and I'll just quote from a commentary that I put together with the director from the Center for Disease Control in Atlanta, basically single platform conclusively and convincingly demonstrates that the single platform method significantly improves variability of CD4 and CD8 T cell counts both within your own laboratory and between laboratories, compared with conventional methods that use flow cytometry plus hematology. At the same time that we published this, an article came out of the UK National European Quality Assessment Schemes that was looking at single absolute platform, absolute counts from single platforms versus dual platforms in about 13 countries, and came to the same conclusion that basically our results suggest absolute cell subset enumeration should be performed by single platform technology. That's not to say that the old technology is wrong or bad. In your own laboratory, using your same hematology instrument and your flow cytometer, the results are very reproducible and accurate. So again, just to go back to the panels, we had beautiful panels that we had developed, essentially two-color 6-tube panels. The problem here, of course, is that we were using light scatter gating. The ability of multicolor technology allowed us to add CD45 and essentially allowed us to gate on lymphocytes and simultaneously analyze two or more other parameters in a single tube. And so the original super comprehensive, quality-controlled immunophenotyping panel was 6 tubes with 2 colors in each tube. The first tube, you gated on lymphocytes by forward angle light scatter, right angle light scatter. Then you measured the percentage of CD45 bright positive, and you had to correct for both purity and recovery, which we did for every subsequent subset. And here are the 5 other tubes. Again, as Dr. Knight alluded to, you get BTNK, T helper, T suppressor. This, however, was a 6-tube panel. We were all very happy when the new technology allowed us to get essentially 6 colors in a single tube in all of the subsets. What we have done in our laboratory is, in addition to, on the left, the 6-color BTNK T helper T suppressor panel that you do in a single tube, we have added a second tube that allows us to add several quality control measures to our immunophenotyping analysis. We have the ability to simultaneously measure CD3 percentages in both tubes. And again, as Dr. Knight alluded to, this needs to be less than 4% in our laboratory to pass QC. We also add HLA-DR to CD3, which gives us essentially what we call an in vivo rheostat of immune activation. So the percentage of T cells that co-express CD3 and HLA-DR are an indication of in vivo immune activation, which for us has been particularly helpful not only in HIV in terms of establishing the level of activation that is ongoing in many of our patients, but also has helped us almost as a diagnostic in evaluation of patients suspected of having primary immunodeficiency disease. So in the next slide, I'm going to show you what we have developed in the laboratory, and I apologize, it's a very comprehensive slide. My technologists in the laboratory also think it's very comprehensive and complex, but it allows us an extremely valuable quality control tube to enumerate both percentages and absolute counts. So we can go in order on the right as far as the QC parameters go. And again, we have lymphosome with BTNK. We also have CD3, CD4 positive plus CD3, CD8 positive, essentially giving us a T cell total that must be plus or minus 10. If we fail those QC parameters, we do have standard operating procedures for follow-up, because this is not always technology. It could be a biological phenomenon where you fail this parameter. Number 3, we have obviously the percent in the 2 tubes. This has to be plus or minus 4. And then we have the absolute count in both tubes. The problem with absolute counting, if you're only doing it in a single tube, you really have few choices for quality control except previous results. So if you don't happen to have a previous result on your patient, your answer is always going to be correct. With the second tube, the absolute counts have to match the second tube by plus or minus 15%. If they fail, the technologists have to go back, reanalyze, regate. If it fails again, we restain the sample. So this is a really good tool for us. It's replete with functional automation. So they're basically plugging in numbers. The calculations are all performed in an automated fashion. And it's a worksheet that conforms to all CAP requirements and regulations. So now that we have these beautiful assays, really all of this technology was developed in concert with the necessity to accurately and reproducibly measure CD4 in HIV-infected persons. I've been involved in this, again, with the NIH for over 30 years. And we recently, well, it was recently, I guess it's not so recently, 10 years ago, published all of our experience with measuring CD4 in HIV-infected persons, primarily in the pediatric realm. The next slide just summarizes everything that CD4 has been utilized for over the past almost 40 years. The number one use for CD4, and it was this way until very recently, it was the best prognosticator we had, both for the risk of progressing to AIDS and death. In fact, if you go online, there is still an application online where you can plug in the sex, the age, and the CD4 count, and it will estimate the time to AIDS and death. That all changed, of course, with the advent of very, very successful antiretroviral therapy. CD4 count was also used to classify our patients. So we had a formal classification system for the level of immunodeficiency. It was used to, and this criteria changed over the years, where you had to be at a certain level of threshold of CD4 before you would get antiviral therapy. Of course, today that has changed. All infected persons today are supposed to receive antiviral therapy. CD4 in diagnosis, we were allowed to make a diagnosis of HIV infection if we had no ability to do serology. CD4 was used to determine whether or not you would vaccinate with live vaccines. CD4 was used to monitor patients, and so whether the antiviral therapy, whether they were complying with their therapy or in fact whether there was immunological failure for CD4. And so really CD4 and HIV propelled us forward for the use of clinical flow cytometry in the laboratory. So now we get to the next part of the talk, which is really immune monitoring, which is, as we're alluding to it today, routine immunophenotyping beyond HIV. In this context, we're going to be talking about primary immunodeficiency. And so again, I think Dr. Knight gave us a very nice description, general description of primary immunodeficiency. I'll give you a little different explanation or definition, if you would, which is a little more scientific and clinically inclined. The other thing I want to mention here is there is really a push in the community to change the name, and I think this is important because words matter. In 10 years, when you Google primary immunodeficiency, we don't know what will come up. In all likelihood, you will be Googling inborn errors of immunity, which the field considers this to be much more accurate description of primary immunodeficiency disease. Next, we're going to really cover the classification of the primary immunodeficiency disease, and we do this because I want to introduce to you the breadth and scope in terms of the numbers and categories of primary immunodeficiency disease. And lastly, once we kind of have an idea of the classification scheme, we're going to go through the classification scheme and the different groups. And depending how much time I have at the end of the presentation, we'll see how far we get. But basically, we're going to kind of describe how routine immunophenotyping is used in primary immunodeficiency disease. And in order to do that, I'm going to show you specific cases that I've encountered over the last 25 or 30 years as basically a clinical flow cytometrist. So what is primary immunodeficiency or inborn errors of metabolism? As Dr. Knight alluded to, it's genetic. This is a congenital abnormality. You're born with it. So either you've inherited the gene or you've developed a mutation in a germ cell, and you are going to carry that mutation forward in all the cells of your body that can affect any particular component of your immune system. As we mentioned, results clinically in recurrent or severe and difficult to treat infections. The newer discoveries of, and why we call it inborn errors of immunity, it's not necessarily deficiency, it could be dysregulation leading to autoimmunity or autoinflammation, and there's a whole new category related to both autoimmune, congenital, autoimmune, and autoinflammatory diseases that are due to mutations, congenital mutations in components of, in genes related to components of the immune system. And again, as you saw from the posters that are produced by the Modell Foundation in collaboration with a lot of other corporate entities, basically to educate the public about primary immunodeficiency disease, which is much more common than anyone ever suspected. So the classification in 1973, which is now 45 years ago, the first publication of the primary immunodeficiency diseases was released, and there were 14 primary immunodeficiency diseases. The WHO wanted to do this because it was getting inordinately complicated with 14 diseases to try to manage them, for people to understand what they were. So in 1973, they convened an expert committee, reviewed each of the primary immunodeficiency diseases, and put out a publication. And the meeting was in 72. They put the publication out in 73. So this has been convened by the WHO every 2 years since that time. So every 2 years since 1973, there's a new publication that lists every single primary immunodeficiency disease. This project was taken over by the International Union of Immunological Societies in 2008, who at that time put out a mission statement, which is basically to provide an up-to-date classification of every primary immunodeficiency disease. Why? Is to assist in the identification, the diagnosis, and management of patients with these uncommon conditions. Today, it's the most current and complete catalog. There's actually an app for it on either your Android or iPhone, and it really provides a framework for the diagnostic approach to primary immunodeficiency disease, and very useful for our clinical laboratorians and clinicians. So I apologize for the entry of this slide. This is the publication. I encourage anyone who is interested. It's a Bible. It's a reference guide. Contains an inordinate amount of information and allows you to essentially probe any disease entity and every single autoimmune disease. So we're going to go through some of the components of this publication, which we'll use to proceed as we go through cases, etc. So just to give you kind of an idea of where we've come from since 2073, with the last meeting in 2015, we had 269 classified diseases. The last publication, which just came out in January of this year, listed 354 individual primary immunodeficiency diseases. Clearly, that's too many without some sort of classification and separation. And I believe the next slide lists the individual categories that have been worked and reworked since 1973. There are now nine categories. It's a little bit of a busy slide, but what I've done for you is I've summarized the numbers within each category that have appeared within that category over the past 10 years with each of the 5 individual consensus classification meetings. So you can see for the combined T and B cell, we had 31. In 2007, we now have 49. Some of the newer disorders that I mentioned, intrinsic and innate immune defects, from 7 to 32, almost a 5-fold increase. The autoinflammatory diseases and the diseases in immune dysregulation, I mean, some of those have increased 3 to 4-fold. So these are the categories. This is how all of the diseases are classified, and we'll go through these, some of these categories and cases that I've encountered over the years in each of the categories. So with this many primary immunodeficiency diseases in all of these categories, why is flow cytometry so particularly useful? Well, what are the primary immunodeficiency diseases? If we reduce them to just the basic abnormalities, right, it's abnormal cell development and differentiation, abnormal molecules in and on cells, and abnormal cell functions. Each of the things that Dr. Knight alluded to earlier. What do we do with flow cytometry? We measure subsets, we measure cell markers, and we have the ability to measure functional abnormalities. I would venture that of the 354 diseases, if you had enough patient specimens, resources, you would be able to identify by flow cytometry a laboratory abnormality associated with a particular abnormality in that disease. So again, these are the panels. These are our 2-color, 6-color panel, just to show you, because some of the cases that I'm going to show you, we were identified using this panel, and others were identified using our new 6-color, single platform, 2-tube panel. Before I go any further, those of you that work in the adult world don't necessarily work about normal ranges, age-associated normal ranges. This is absolutely key in the evaluation of routine immunophenotyping results in the newborn to 5-year-old population, as both percentages and absolute subsets change dramatically. We have done some work in characterizing these ranges, and I've published this in a book. The normal age-associated ranges for lymphocyte subsets are absolutely essential in interpreting what is normal and abnormal in children. So back to the categories. We'll start with table 1 are the combined T-cell and B-cell immunodeficiencies. And again, on the left are the severe combined immunodeficiencies, and we'll spend a fair amount of time talking about these. There is no immune deficiency disease that is more aligned with flow cytometry than the severe combined immunodeficiency diseases, because as you can see, they're classified according to the phenotype that is established in the clinical laboratory. The group of combined immune deficiency diseases on the right are generally, but not always, less profound, but they are combined nevertheless. What we mean by combined is that we are affecting both of the major components of the immune system, both the humoral or antibody component as well as the cellular component of the immune system. That's where the term combined immunodeficiency comes from. This is the table that's listing the severe combined immunodeficiency diseases on the left, and you don't necessarily need to read all the details here. It's just to show you the format of the table. The table lists first the disease entity, and the way that the expert committee has changed the disease entity is they are trying to steer away from nicknames and name the diseases more according to the molecular etiopathogenic gene or genes associated with that disorder. So hyper-IgM deficiency is now classified according to the underlying mutation. Bayer lymphocyte syndrome is now classified according to the mutation of the genes that really generated that phenotype. Then you have the genomic defect, so that's the gene, as you are well aware. If it's italicized, it's listing the gene and not the protein. They list the mode of inheritance, online Mendelian inheritance, and man number. This is an extremely valuable resource. If you click on that number or go to this website, it lists virtually every publication associated with that particular genetic disorder. You will get the sequence, you'll get the localization in the genome, you'll get any reviews on that disease, any publications, treatments, etc. And then it tells you what is affected, so T cells, B cells, or immunoglobulin, and then any associated features. So each of the tables contains this information, and then as we go, I will show you the table associated with any particular case that I show you. So here was a case that we got approximately 25 years ago. This was the phenotype, essentially no T cells, mostly B cells, and very few NK cells. There's only a few genetic diseases that will give you this phenotype, which is one of the advantages of flow cytometry, because now we're not looking at 355 diseases, we're looking at 5 to 10 diseases. So this allows you to focus and rapidly turns around the potential for diagnosis and treatment, which is critical in severe combined immunodeficiency. So in this case, it's going to be common gamma chain, which is the most common genetic cause of severe combined immunodeficiency. And as we'll see downstream, other in the molecular sequencing pathway, other signaling molecules associated with severe combined immunodeficiency. And just to remind us that all the dot plots in flow cytometry are really looking at cells. This is just a schematic of the common gamma chain mutation affecting 5 different cytokine receptors. So the common gamma chain is the signaling moiety that provides the connection from the specific receptor and cytokine to signaling within the nucleus for T cell growth and differentiation. Common gamma chain then signals via Janus kinase 3. So as you can imagine, a mutation in common gamma chain or Janus kinase 3 gives you the same phenotype. You will not be able to develop T cells or NK cells. You will develop B cells. But as we learned, B cells require a functional IL-21 receptor. So all of our patients early on with X-linked severe combined immunodeficiency, they got maternal transplants without immune suppression or myeloablative therapy, ended up with humoral immunodeficiency, and they're all on IVIG, which is still life-saving. Our more recent protocols for transplant do eliminate all residual B cells so that the patients will re-engraft with all functional components of the immune system. So another patient we saw, and again, the phenotype here determines the classification. This is a T minus, B minus, NK, and you can see the summary of the phenotype. Virtually all natural killer cells in this patient. Compared to the control, I apologize for the change as we modified the slide format, but the phenotype on the left is the patient. The phenotype on the right is our healthy control. Really, T minus, B minus phenotype is associated with molecules that are responsible for the generation of our antigen receptors, basically doing double-stranded DNA breaks and repair. And so recombinase activation genes are responsible for double-strand breaks in the DNA encoding for both the T cell and the B cell receptors. Some of the other genes associated are more associated with the repair of the double-strand break, but the phenotype is classical. And again, with this phenotype, we're only looking at somewhere between 5 and 10 genes. Within that category of severe combined immunodeficiency is the Omenn syndrome. Omenn syndrome is actually caused by the same genetic defects that cause severe combined deficiency. However, these are hypomorphic mutations in those genes, which means that you have a protein generated from that mutated gene. However, the protein is dysfunctional. So you tend to get T cells. However, the T cells have a very limited repertoire, and they're abnormally activated. So we have used this information to help us screen for leaky skid or Omenn syndrome. So these patients can have relatively normal numbers of T cells, as you'll see in the next slide. So this patient had a normal number of T cells. However, the phenotype is extremely abnormal in that almost all of the T cells were activated. There are other tests that we do. For example, we measure the repertoire. We also measure naive and memory T cells, which again help our physician establish that this is highly abnormal. We will then seek genetic sequencing, again, looking for the genes associated with severe combined immunodeficiency. I want to change the subject a little bit here. The severe combined immunodeficiency disease is a medical emergency. And the way that we identified these children in the past was clinically. They came to us extremely ill. Over the years, we have established that the earlier you diagnose a severe combined immunodeficiency patient, the better the outcome. So we now know that if you do not detect severe combined immunodeficiency disease in less than 90 to 100 days, the length of stay increases dramatically for the transplant procedure. The outcomes decrease dramatically as the patients age. So in approximately 15 years ago, there was a strong advocacy to get newborn screening on board for severe combined immunodeficiency disease. And in fact, in 2010, the Department of Health and Human Services announced that all states would have to add newborn screening to their repertoire. So in less than 10 years, all states except 5 states are now performing newborn screening, which amounts to 92% of all of our children. Very simply, what we're doing is we're using the same Guthrie card we use for all other newborn screening testing. you punch the card out into a DNA extraction media, and you measure T-cell receptor excision circles. Very simply, this gives you a measure of the amount of T-cells that are circulating in that patient's peripheral blood. Extremely valuable, rapid test, now performed relatively inexpensively, and performed on 92% of all children born in the United States today. What this means for the flow lab is that we now are in a position to receive any patient's specimen that has screened positive in the newborn screening assay. So basically, in our state of California, any infant that has a non-normal TREC will immediately have a CBC and a differential. Often with severe combined immunodeficiency, they're going to be terrifically lymphopenic. Flow cytometry to measure absolute T-cell count, as well as measuring naive T-cells. So the rules are that any infant that has less than 300 T-cells or more T-cells, which we saw in Omenn syndrome, but no naive T-cells, immediately get hospitalized or put in isolation, and we immediately work them up for transplant. So this program has been remarkably successful. It's been 100% sensitive to date. This is fantastic. However, what we need to keep in mind is that newborn screening for severe combined immunodeficiency detects only 24 of the 350 primary immunodeficiency diseases. This means that there are over 300 diseases that are not detected by newborn screening, which means we still have to remain diligent both on the clinical side as well as the laboratory side. So back to our combined immunodeficiency diseases, and now I want to show you a few examples of patients that we've seen over the years that passed newborn screening but were severely immunodeficient. And essentially, some of the patients ultimately did not survive. Others, we were able to diagnose them early and get them into transplant. So as we mentioned, the diseases on the right are combined immunodeficiency, which is not severe, in most cases, less profound. So let's look at a few of those cases. So I'll start with a case study. I'm doing this because it was a very interesting case for us in the laboratory, and it really taught us a lesson. So this is a previously healthy child of Mennonite descent, came to us with rhinovirus pneumonia, and basically in severe respiratory distress. But we showed in the lab that he had normal immunoglobulin levels with slightly elevated IgA and IgM. He had an elevated lymphocyte count, but he had no functional proliferation responses. Because of his ethnic background and near absence of CD8 positive cells, we sequenced DAP70, which we know is a gene associated with a combined immunodeficiency disease, and sure enough, he had the mutation. TREC levels, however, at newborn screen were normal. So this case was interesting to us because we didn't do the original immunophenotyping. This report came to us that he had low CD8s. So what happened is this mother now was having her fourth child, and they had contacted us to do the immunophenotyping. So this is ZAP70, and again, this is what you see in the table. So it's ZAP70 deficiency. The gene is in ZAP70. It's autosomal recessive disease, low CD8 positive, normal CD4s but poor function. B cells are normal, immunoglobulins are normal, as I already showed you. And they may have immune dysregulatory autoimmune disease. This is what we saw in the laboratory. And I'm gonna tell you up front that this is not what we expected. If you just look at the immunophenotyping results, comparing the patient, the lower right-hand corner, compare the patient immunophenotyping percentages to our normal range. CD3 was a little low, CD8 was a little low, CD4 was also a little low. CD19 was within range, and the NK cells were high, mostly because the CD8s were low. And so obviously they have to equal 100%. So at first glance, there's nothing truly remarkably abnormal about the CD8s. However, at closer inspection, if you look at the normal versus the patient, they're missing the bright CD8 positive population. Now, if you're not paying particular attention, this may go right through without any particular attention. And so I just wanted to bring it up to show you that these deficiencies can be subtle in some cases. If you look in the patient, there are no bright CD8 positive cells. And we are not the only ones to observe that. Patients with the combined immunodeficiency diseases may pass newborn screening. This was published, again, relatively recently, less than 4 years ago, that newborn screening is not going to pick up all combined immunodeficiency diseases, and in this case, some severe combined immunodeficiency diseases. Again, back to our table, I'm going to give you a few more examples of patients with essentially combined and potentially severe combined immunodeficiency that passed the newborn screen. The next case is a patient who had been diagnosed by us with MHC class II deficiency. MHC class II deficiency disease is interesting because the mutations are not in the MHC class II genes. The mutations are in genes associated with the transcription of MHC class II genes. Patients need MHC class II expression on their lymphocytes for two extremely critical functions. One is the selection of CD4 positive T cells in the thymus, so positive selection of functional T cells. The other is for antigen presentation. So two extremely important functions that are required. And if you have non-functional T helper cells, you're going to have a non-functional humoral immune system, so hence the combined immune deficiency diseases. So this is a patient that we saw relatively recently, very difficult to diagnose. They had never essentially had a routine immunophenotyping test performed because they assumed that the patient had a defect in a phagocyte. So they essentially established that he had a phagocyte functional defect, primarily established by the types of infections that he had encountered, and I'll show you a little bit about that in the next slide. So they were working the patient up for transplant. The blood happened to come to my lab. I asked what they were looking for, and they said, well, we're working up for transplant, but we don't know the underlying cause of the disease. And I said, well, what does the immunophenotype say? And they said, well, we have not performed it here. So I said, send us the sample. CD4, CD3, you can see there's a low CD4 positive T cells compared to CD8. So 12% CD4s, 31% CD8 gives you an abnormal CD4 CD8 ratio right off the bat. And then my favorite tube, HLA-DR. If you look at the HLA-DR tube, there are gross abnormalities. This is a sick child with no CD3 HLA-DR positive cells, but more telling is the absence of HLA-DR positive CD3 negative, which are your B cells. Within that upper left quadrant with the arrow pointing to the left, there should be at least 46% of the events in that quadrant. So this patient had no HLA-DR. I immediately called the physician. Unfortunately for this patient, it was too late. The patient by now was 5 years old, extremely ill. However, due to the presentation of the patient and confusing the clinicians, thinking that this was a phagocytic defect, we thought that it was important to publish this, and we published this about 3 years ago, showing clearly that this presentation in a patient that has passed newborn screening, you have to perform a routine immunophenotyping with HLA-DR. The next case that we're going to present is another combined immunodeficiency disease. And again, this was very enigmatic because everybody considered this a humoral immunodeficiency, but nobody can understand why these patients had diseases and infections associated with a T-cell immunodeficiency. Well, it turns out that hyper-IgM syndrome can be both a T-cell or a B-cell related defect. The most common form of the hyper-IgM syndrome is a T-cell defect, and that's a defect in the CD40 ligand. CD40 ligand is a regulated molecule on T cells, absolutely required for co-stimulation of antigen-presenting cells, which in turn stimulates the T cell to mature. So it's an essential co-stimulatory molecule. It is also absolutely essential for class switching of B cells from IgM to the more focused and specific antibody, IgG and IgA. And so you can have mutations all along the pathway, either in the CD40 ligand, which is the T cell defect and by far the most common, and that's X-linked inherited, or autosomal recessive, which is the CD40 receptor on antigen-presenting cells. Anything downstream of those two defects will not occur, so that results in a T-cell immunodeficiency as well as a humoral immunodeficiency. As you go down the pathway, the mutations in the DNA repair enzymes will lead to inability to class switch, which is a less profound disease, and has been removed from the combined immunodeficiency classification and put into Table 3, which are the primarily antibody and B-cell diseases. So clearly this is a disease that we were interested in because we thought we could develop a diagnostic test, which we have done and published. But more interestingly, and in the context of our presentation today, what we noticed, the first 6 patients that I tested after we developed the new test to detect CD40 ligand inactivated T cells, each of these patients showed a significantly elevated CD4-CD8 ratio. So this is an extremely valuable screen. If you are providing the service of CD40 ligand, you can ask the laboratory that has performed routine immunophenotyping on these patients. If they suspect hyper-IgM, simply ask them, what is the CD4-CD8 ratio? If it's high, then I would highly recommend either you sequence the gene or perform a functional test for a functional CD40 ligand. So now we get into group 2, immunodeficiencies. These are combined immunodeficiencies, but the immunodeficiency is not the primary defect in the patients. These are immunodeficiencies associated with other congenital diseases. And again, these are the group 2 diseases, and I'm going to show you an example here with a case study. This is a patient that was born 34 weeks gestation, to approximately 2,000 grams. What they observed during the patient's stay was that the patient had no thymus. They had other cardiac abnormalities and biochemical abnormalities associated with calcium and metabolism. The triad of these 3 disorders really clinically points to DeGeorge, so we performed molecular testing and sure enough identified a deletion in 22q11.2, confirming a diagnosis of complete DeGeorge syndrome. In the past, patients with complete DeGeorge syndrome did not survive past the age of 1 year. Fortunately, with the development of thymic transplant, we are now able to provide treatment for these patients. So this, again, is just the table. This is DeGeorge syndrome, is the disease, the genetic defect. These are either deletions or specific mutations in the TBX1 gene. The mode of inheritance depends whether it's a deletion or a single base pair mutation. And again, single circulating T cells from moderate to severe DeGeorge can be normal to very high, but they are abnormal with a decreased repertoire. And again, this is what the patients with complete DeGeorge syndrome might look like. This is with permission. They have a rash over their entire bodies, and these patients will not survive unless they are able to get enrolled in a thymic transplant protocol. The thymic transplant protocol is fascinating because the thymus is essentially recovered from cardiac surgery in pediatric patients. These used to be thrown away. At Duke, when there's cardiac surgery, the laboratory is called. They recover the thymus, they put it in culture, and they have a bunch of thymus in their thymi in their incubators growing. When the patient's ready for transplant, they essentially put 6 to 7 incisions in each quadriceps and transplant slices of these thymic cultures into the quadriceps. If you don't have a thymus, you do not have functional T cells. The thymus is 100% necessary for the education of mature, selected, positively selected T cells. So in these patients, you can have super high levels of T cells, up to 3,000–4,000 per microliter, but they're completely non-functional, they're extremely activated, and they're all memory T cells that are non-functional with an extremely limited repertoire. So once we do the transplant, why do we use the routine immunophenotyping? Essentially to monitor engraftment. This is just showing you very quickly a series of 20 of these patients, courtesy of Rebecca Buckley, who shared these slides with me, showing the time course to reconstitution of normal T cells that are essentially educated not in the thymus in the chest, but in the thymus in the quadriceps muscle. She has a whole cohort of these patients. She calls them her family, and there's about 75 of these kids that are surviving today, some over the age of 30 years old. So extremely valuable. The laboratory plays a critical function in measuring engraftment, because once these patients get past a certain percentage of naive T cells, which can only come from these transplanted thymi, then they take them off immunosuppression, and the patients go on and do very well. As we go on in the categories, we get to group 3, which are the predominant antibody deficiencies. And all I'm going to say here is this group classified primary immunodeficiency disease is based on laboratory parameters. So no B cells, no IG, some B cells, some IG, normal B cells, hyper IgM essentially, or isotype specific immunoglobulin changes. But again, all laboratory parameters. So another case study is a patient born uneventful pregnancy, had a history of otitis media, Haemophilus influenza, encapsulated bacteria at 5 and 11 months. So you'll notice right away the patient is older. Right? This is absolutely the case for the humoral immunodeficiency disease. The patient got all their immunizations. They were right up to date. He's the fourth child of unrelated patients, and he had only sisters. So he was referred for a workup at 15 months of age, and we noticed in our laboratory that he had essentially no immunoglobulin. We tested him for specific antibody, no specific antibody, and by flow, we observed that he had no B cells. So right off the bat, we know that this is a hypogammaglobulinemia. We don't know if it's X-linked or autosomal. We had no family history to link it to X-linked. And again, this is just in the table, the classification for X-linked agammaglobulinemia. We know that this is due to a mutation in the Bruton's tyrosine kinase. Bruton tyrosine kinase is absolutely essential for the maturation and development of normal B cells out of the bone marrow. So this is the phenotype, and again, this is from our 6-tube 2-color panel. Very clearly has no B cells. What is interesting here and what I wanted to show you is that we are able by flow cytometry to actually identify if this is X-linked or autosomal, basically by measuring intracellular Bruton's tyrosine kinase. We developed the test. It's a beautiful test because it's one tube with all the internal controls. T cells have no BTK, that's your negative control. Monocytes have BTK, okay, so that's your positive control. And then B cells have BTK. So if the patient has no B cells, so this is a normal, and you notice in this case, the patient has no B cells, so we can't look for BTK and B cells. But you notice that there is no BTK in monocytes. So this is a test that we developed essentially following screening for the mode of inheritance of agammaglobulinemia. And so we're getting on. I think we're going to end with this case. The diseases of immune dysregulation are fascinating. We spent many years looking for the proverbial suppressor cell within the CD8 population. In fact, we used to call them suppressor cytotoxic T cells. We don't do that anymore. We call them CD8 cytotoxic T cells because we figured out that the suppressor cell was actually a CD4 positive cell. And so within immune dysregulation diseases, many of these diseases are and have been amenable to analysis by flow cytometry. And so these are essentially diseases of immune dysregulation that lead to autoimmune disease. This is our last case study. Our patient was born basically after normal, uncomplicated pregnancy, got all routine vaccinations, no complications. But on their second or third year routine examination, it was observed that she had an enlarged spleen and many enlarged lymph nodes. According to our parents, she really had no infections and growing and developing normally. So biopsy of the lymph nodes, because of the unusual presentation, so that there were essentially enlarged follicles, an increase in the number of immunoblasts and plasma cells, but no infection. We did karyotyping, no abnormalities, no clonality was observed in lymphocytes of the lymph node with B and T cell clonality assessment, so it was not cancer. By flow, we measured by routine immunophenotyping. We observed that she had, the test failed for the CD3, CD4 plus CD3, CD8 by more than 10%. And so what we observed by flow was that she had a significant number of CD4, CD8 double negative T cells that express the alpha beta form of the T cell receptor. So again, routine immunophenotyping gave us a clue. The clinical presentation gave us a clue. We performed our essentially autoimmune lymphoproliferative disease panel, which gave us one of the parameters required for a diagnosis of ALPS. The slam dunk was when we sequenced her FAST gene and she was shown to have a mutation. So very quickly, again, here is the classification table showing disease of immune dysregulation with ALPS. There are approximately 6 genes associated with ALPS. They're all associated with mutations in genes that control apoptosis of lymphocytes. The criteria, just so that everybody is aware, do involve flow cytometric criteria. The old criteria did, and the new criteria do as well. Flow cytometry for the measurement of double negative T cells, as well as flow cytometry for the measurement of functional apoptosis in lymphocytes. So this is an A form that we have been using to identify double negative T cells. So very simply, you want to identify T cells that are CD4 and CD8 double negative, and then you measure the percentage of the CD4, CD8 double negative T cells that express the T cell receptor, alpha beta form of the T cell receptor. And the normal range that we've established is less than 2.5%. If they have higher than 2.5% of their T cells that are double negative and express the alpha beta form of the T cell receptor, then they do satisfy one of the components of the ALPS criteria. And then these are just to go over the other criteria, the other categories. We could go on in these criteria, but with
All right. Thank you very much, Dr. O'Gorman. We're ready to transition into Q&A, which will be hosted by both Dr. O'Gorman and Dr. Knight. I encourage any of you who do not want to ask your question live to go ahead and type it into the Q&A session on your screen.
So, have we answered the questions that are being asked through the application? Have we answered any of the questions?
No, those are, go ahead, Dr. Knight.
Oh, sorry. Yeah, so we were going to go through them orally at the Q&A session so we can have all of our audience.
Yeah, we're live now, you guys. We're live, and it's time to do that.
Okay.
I'll do the first three. So FALS and RALS, what do they stand for? FALS is forward angle light scatter. RALS is right angle light scatter or side scatter. Mulia asked, what does TREC stand for? TREC stands for T cell receptor excision circles. This is an episomal piece of DNA that is created when you functionally recombine the gene to create a functional T cell receptor. You actually cut out and splice out a circle, and you can actually measure that circle. It's a consistent piece of DNA that is measured with a PCR assay, and the PCR assay for the measurement of TREC is the basis of the newborn screening test for severe combined immunodeficiency disease. John Wong asked if there's an update to the single platform absolute count determinations. I would suggest that you, I hate to say Google, I would prefer that you use the National Library of Medicine or PubMed, but I think Google is pretty good and will give you, there are several updates to the application. There are new guidelines that are published by the Clinical Laboratory Standards Institute, and so I would just recommend that you actually search because there are several publications. Let me see, apart from the TBNK markers and HLA-DR, what other markers do you run for flow cytometry panels in subjects with suspected immunodeficiency? That's a very good question, and we in fact have a few other panels. I think I mentioned within, in the lecture that we have an ALPS panel, we have a leukocyte adhesion deficiency panel. There is an oxidative burst assay that we perform, which is more of a functional test for chronic granulomatous disease. There are several tests, and again, I would refer you to the literature. There are several good publications. And again, if you just search flow cytometry and primary immunodeficiency disease, there are actually a couple relatively recent reviews on applications of flow cytometry and immunodeficiency. Really, the scope and breadth of the assays is really difficult to answer in one question session. I'll go at number 5 again. Dr. Knight, I apologize for commandeering the question session, but it looks like they're mostly related to the primary immunodeficiency disease.
Yeah, no, not a problem at all, Dr. O'Gorman.
Okay. Is there a chance that flow will be replaced by molecular testing? That's a really good question. We get it all the time. The issue with molecular testing today is that it's how long it takes and how much it costs. I can give you a provisional diagnosis of immunodeficiency disease in about 2 hours. In order for us to get a full comprehensive clinical exome, for example, if we're searching for the gene of interest, can take up to 6 weeks. So there's a time frame involved. We can actually get a patient to transplant sometimes before we get a molecular diagnosis. Now, that's not to say that that's going to improve. Sequencing is rapidly improving, as we all have seen with the cost. The sequencing with time and turnaround time is also improving. So will molecular ever replace flow cytometry? I'm not anticipating that that's going to happen within the next 5 to 10 years. I think the next ones may be for our webinar sponsors to answer. Is there CE credit available? How do I receive it? Marcia, can you answer that?
Yes. To my knowledge, we're not offering any CE credit for this webinar. If that's a possibility, we'll get back to everyone, but this webinar is not CE certified. Mm-hmm.
Are we able to get the slides again, Marcia?
Yeah, we'll have them posted for you guys in a couple of weeks. And those of you who've been attending this full series of webinars, you would just return to the same link that you've had. They're all kept together once you log in. If you're new, you will get an email from us when they're posted, and you'll be able to go in and download them.
Okay, and I think the next question, number 8, from Haibo Lee, is probably for me. How do you evaluate CD4 and CD8 double negatives or CD4 and CD8 double positives when CD3 reliably is out of range? The answer to that question is simply you gate on CD3. And so regardless if it's in range or out of range, you just make your denominator the CD3 positive subset, and then you evaluate the expression of CD4 and CD8. And so this is done in a couple, there are a couple panels that folks have developed over the years, and this is published. I wrote a review recently on how to do this. It's published in the ICCS, International Clinical Cytometry newsletter. You can Google that, look that up, and that was published in the newsletter last year from the ICCS. Number 9 by Sura Saxena. Seems like the PID diagnostic space is mostly being driven by CAP, CLIA, governed flow cytometry, laboratory developed tests. Is there a need for more in vitro diagnostics in this space other than TBNK? I applaud that question, and the unequivocal answer is yes.
So if I might just add a little bit to what Dr. O'Gorman said. Yes, there's definitely a need, but I'd also like to mention the fact that the CAP, one of the CAP committees is also working on some ways to perhaps bring a little more synchronization into these assays. It is difficult because every laboratory seeing these patients is, catering to the needs of their patients and developing assays that best fit their practices. But I am in agreement that we definitely need more IVDs.
Yes, and Dr. Knight and I are both involved on a committee to bring standardization to some of the primary immunodeficiency disease tests. The next question by Iman Mulia. Dr. Knight, I'll let you go ahead and answer that again.
Okay. So this question is, what do FALS and RAL stand for? So FALS is forward angle light scatter, and RALS is right angle light scatter, and they correspond to what we've also termed as forward scatter and side scatter, which respectively are to do with the cellular size and complexity. Are there any other questions from the audience? These are the ones that were sent in to us. We just had another question.
Yeah, Go ahead.
Here's another one by Iman Mulia. When we run TBNK patient samples, do we need to run control samples along with it, like CD4 low control, or is it enough to check QC? We run a control specimen with every run that we perform for TBNK analysis. And that is what is recommended by our, at least within the United States, our regulatory agencies require that you run at least 2 controls if you're providing quantitative results, which absolute counts are. So we run a low and a normal cellular control with each run that we perform. Do you want to comment, Dr. Knight, on what you do in your laboratory?
No, I agree. Per our regulations, we do run a low CD4 control, commercial control, and a sample from a normal healthy subject for our TBNK panel, and that's with every run. So if we're doing 2 independent runs on a day, we will run 2 controls for each run.
Okay. That's all of the questions. So thanks, everyone, for joining us for this webinar. We look forward to seeing you in our next series webinar. And an additional thanks once again to Dr. O'Gorman and Dr. Knight. Everyone, enjoy the rest of your Good Friday and have a happy Easter.
Thank you.
Thank you. Thank you, Marcia.